Good morning. Thank you, Dr. Perry. How is everyone doing? Feeling good? Awake? Ready for day two? Good. Well, you don't really sound it, but I'm just going to say good anyway. There you go. There you go. So I want to first thank the Beyond Flexner Alliance board members, the planning committee, and the co-host, A.T. Still University and Arizona State. Thank you for this brain-stretching conference and for assembling us all under one umbrella to share how we're moving the dial on social mission. COVID can make our work feel so isolating, and the conference has provided the dose of inspiration we need. I want to give a special thank you to Dr. Fitzhugh Mullen. My inaugural role as Associate Provost for Social Mission and Academic Excellence at Chamberlain serves as a constant reminder of Dr. Mullen's commitment to improving healthcare outcomes. So it's my honor today to be here to discourse on the power of social mission, to hear inspiring narratives that amplify what our colleagues are doing and have done, and to call attention to the critical actions that are still needed to advance health equity. As we know, policies and legislation have not been enough to eliminate healthcare disparities. When the Civil Rights Act of 1964 was signed into law, I was a baby. It was a momentous point along a long and arduous journey that brought us one step closer to social justice. One of the major provisions of the CRA was that it banned discrimination based on race. Or did it? Of course it did. You see it on documents when you apply for jobs. It says we're an equal employer, equal opportunity employer. All qualified applicants will receive consideration for employment without regard to race. So the real question is, did the CRA completely ban all forms of discrimination? That's not a rhetorical question, right? No, it did not. The CRA of '64 was a partial victory. And I say that because it lacked the power to dissolve covert discriminatory attitudes, practices, messaging that is propagated in our textbooks, discriminatory learning environments, admission practices, hiring and promotion practices, the clinical arena, and so much more. So when my colleagues say, come on, can you really? You believe that discrimination is propagated in our textbooks? How is that? Well, during my son's second year of college, he came home one night and he said, Mom, I didn't know that being Black was a risk factor for having a low IQ. Excuse me? What did you say? So he repeated it, and I said, where did you hear that from? And he said, in school, my professor. So your professor told you that being Black was a risk factor for having a low IQ? What's your professor's email address? So my son, because he knows my research, and he's heard me because we're virtual, right? So I'm at home, so he hears me through the walls. And he said, no, Mom, don't call her. She's a really nice professor. I like her. And how many moms are out there with sons? Not that we don't love our daughters, but there's just something about our sons, so we're like, don't mess with our sons. So I was so upset, and he's saying, Mom, don't worry. You know, she's a nice professor. You know, she was just saying what's in the textbook. What? Wait. And it's like 11 o'clock at night. I'm trying to process all this. In your textbook, so immediately the professor and me came out, not the mom, and I thought, did you buy the wrong edition of the textbook trying to save money? My money that you probably spent? So he said, no. And you know, boys, I think it's the right edition. So I said, bring me the book. So he brings it into my room, and I open it. Copyright, like 2 years old. Where? Where does it say this? And sure enough, not only is it inside the margins, right, inside the chapter, but it's also a chart on the side of the chapter that said, the paragraph that says, risk factors for low IQ, number 3, the Black American family. And I'm like, what? How did this happen? So I'm not a social media person. I never really adapted to it. I'm not. But for some reason, after I read that, something ignited me to say, this needs to be posted. And I'm usually the one who says, you don't shame or blame people regarding stereotypes or discrimination, but for some reason I said, I'm going to put this on Twitter, take a picture of this chart, because I want to know if everyone knows that this is happening, that we are actually teaching students in psychology this false rhetoric. So here I am trying to put it on Twitter, and I said, I think you have to do @ people so that, you know, it goes all over the place. So I'm doing my best. That morning I go to work. It's like 9 a.m. I'm at work, and I get an email from the publishing company. Can we speak to you? We are so sorry. We have removed it from our online edition. We would love to speak to you. And I'm like, how the heck did they find me? Like, I've watched too many movies, right? I'm like, how do they know who I am or where I am? So I had the conversation with them, and of course they had their CEO for diversity, their VP for diversity on the call, and all these individuals. And suffice to say, they realized that this information has been in their textbook for years, and they thought that it was just okay to apologize. They had no idea that I had years of research addressing racism and discrimination, race, power, and privilege. And I said to them, it's not a matter of apologizing, you need to know the implications. I said, do you know in the health professions, everyone takes intro to psych. So now I'm trying to process all the students who have been primed to believe this intellectual inferiority when they see Black individuals. And I'm upset because I can recall the 2007 VA report, and they're just like on the call looking like, oh my gosh, she's like including everything. And I said, that 2007 VA report actually talked about the differences in how we treat veterans, Black male veterans and white male veterans. And one of the differences was based on the fact that providers were not giving Black male veterans information. I said, they could be withholding information because they don't think they can deal with it or understand it. Do you realize the power of your textbook and how patients are dying? And it could be because of this false rhetoric. I do not believe that just pulling it down from your online textbook is enough. So we had a longer conversation, and they realized that they needed to do more. They wanted to first find out that how did this continue? They understood that it was based on research back in the 50s that still was allowed, edition after edition, to be put back in the textbook. So when my colleagues say, can you really? The textbooks are propagating messaging that's false. Believe me, you need to do a deeper dive with your textbooks, because when we read our textbooks, we have been conditioned not even to see the disparities that exist, all of us. So the CRA of 1964 could not control for racist messaging that is propagated in our textbooks. And no, it was not a panacea for all the discriminatory practices that ail society. So where do we go from here? How do we continue to move the dial on social mission? James Baldwin once said, Not everything that is faced can be changed, but nothing can be changed until it's faced. What, if anything, have we, all of us, what, if anything, have we failed to face? To what extent are the providers we graduate prepared to eliminate healthcare disparities? In this image, the provider is trying to understand how Ms. Smith's blood pressure and her A1C are not at goal. The provider has been following Ms. Smith for the last 6 months. He's adjusted her medication, yet still, her numbers are falling on the wrong side. He considers increasing her medication once again to address her uncontrolled hypertension. So when I ask students or my colleagues what they believe are the top 3 factors contributing to Ms. Smith's elevated BP and A1C, what do you believe are their responses? Take 10 seconds. Top 3 answers on the board. What are the top 3 responses you believe my colleagues and students have shared for why Ms. Smith's blood pressure and A1C are not to goal? Top answer, still, non-compliant. Non-compliance, even though our textbooks say we should be saying non-adherence, and now some are arguing even with that construct, but that's one of the top answers, non-compliance. Someone else said diet, lifestyle. What else? What do you think is another top answer? Discuss it with the people at your table. 10 seconds. So raise your hand if you thought one of the top 3 answers did not involve Ms. Smith directly. She's non-compliant, she's not taking her medication, she doesn't have access to her medication. Raise your hand if your table did not focus on a factor that really addresses something from Ms. Smith's ability to do or not do something. And if no one is raising their hand, then we have to wonder, what is happening in our classrooms? Why is it that no one to this date is saying we don't know the answer until we have a conversation with Ms. Smith? Why isn't that one of the top 3 responses? That was a rhetorical question. So, are we priming students for bias? As educators and administrators, what, if anything, have we failed to face with our curriculum? Are we providing future providers with broader narratives? Dr. Mullen, he reaffirmed for me the importance of stories and how they broaden our reality. He also believed that data and evidence should be the standard for policymaking. Fortunately for us, we are a data-rich country. In 1979, the Surgeon General acknowledged healthcare disparities and called out in his report that infant mortality was nearly twice as high for blacks as for whites, and that the racial differences were associated with socioeconomic differences. Where are we today? Well, today the infant mortality rate is now more than twice as high for blacks as for whites, in spite of Healthy People 1990, 2000, 2010, 2020, and now we're in 2030. What, if anything, have the reports failed to face? I started nursing school shortly after the Surgeon General's original report. And while funding to diversify the student body existed, the policy and funding were not always enough to create learning environments where individuals felt a sense of inclusion or pride. I remember sitting in the classroom, hearing time and time again, if you're black, you're more likely to have hypertension. If you're black, you're more likely to be obese. If you're black, you're more... What does that do to a student? I graduated high school at 16, So what does that do to a 17-year-old hearing this narrative over and over? It was demoralizing, especially when there's only 2 or 3 people who look like you in the classroom, and whenever the teacher says anything that has to do with black, people get quiet and they look. I actually thought about that when my son came home and said that the teacher had said that blacks had a high risk for having a low IQ. And I wondered, I made that association. Did my son feel the same way I did in the classroom with everyone looking at him? And that's probably why I got so defensive and upset, because I felt like I couldn't really, when I was 17, speak up for myself. But I wanted to make sure I spoke up for my son and to address the injustice. But I digressed. Here I am in nursing school, hearing this over and over and over. And I remember getting into trouble one day because, got kicked out of class actually, because of my impulsivity, I'll admit. But the teacher said, when we got to the musculoskeletal system, oh, and if you are a thin white female, you have a high risk for osteoporosis. And I said, hallelujah. Finally, right? But all she heard was the hallelujah. And what did you say? Out of the classroom, right? So I didn't even bother trying to explain, because I did not believe that she would understand where I was coming from. So I just took the hit. But are our students in the classroom still feeling like this when we create these stories that don't share or don't conceptualize what's really happening? Are we priming students to look at a patient when they have high blood pressure to say, well, that's normal for you. I read about you having high blood pressure, so yeah, 200 over 110. All right, go home and take your medicine. What? You don't know how many family members that I had to advocate for? You're sending him home with what? You think it's okay? A systolic of 110, 120? And you want to send him home? And he's saying he has a headache? Like, help me to understand that. And then usually my colleagues will say, all right, well, keep him another day. And they address the issue. But then I think about all the individuals who do not have advocates and what happens to them. So in 2001, the IOM, in Crossing the Quality Chasm, highlighted the gap between where healthcare was and where it needed to be. Now, while the 6 aims, safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity, attempted to close the gap, we still find ourselves wrestling with inequities. What is in that chasm? What's in that gulf, that gap? What have we failed to face? What do you believe is preventing us from the healthcare disparities, wanting to just get rid of them, to actually crossing over to a place where everyone has the right and is able to achieve their highest level of health? What's in that gap? Is it the social determinants of health? Should we be working on that? Yesterday we heard about the political determinants of health. Should we be focusing on that? I've asked colleagues to tell me, should we be focusing what's inside that gap, or should we be building a bridge to cross over? What do you think? Because some will say, we don't know how deep that gap is. Do we have the resources to go all the way down to the bottom of that gap and address it when we don't even know what's in there in total? Or do we build a bridge knowing that the gap could widen? And then how stable would the bridge be? 2 years after Crossing the Quality Chasm, the IOM published Unequal Treatment, another sentinel document that moved the dial toward social justice. The document highlighted that racism and discrimination remain in many sectors of American life, and one recommendation, and I quote, "Organizations responsible for the education, training, and licensure of health and medical professionals," that's all of us, "should develop special initiatives to increase levels of awareness of healthcare disparities among current and future healthcare providers." That was in 2003, almost 20 years ago. Do all of our providers understand healthcare disparities and how they play out? Do they know how to control for bias? So where are we now? Well, a few years after the IOM's report, in 2007, the VA did their study. And while that VA study was retrospective, they said we have a lot of work to do because we see that the black male veterans, when they complain and they are diagnosed with osteoarthritis, we're not medicating them for pain at the same rate that we medicate white male veterans. How is that possible? Well, the study didn't try to explain for that. It was just trying to see, were there differences? And I commend the VA for sharing their information to help us move forward. So then what happened next? Well, in 2016, Hoffman and others, they looked at this study and they found that some med students and residents harbor false beliefs about the biological differences between black and white individuals. How was that in 2016? So I read further. They said that some providers believe that if you look like me, you feel pain less because you have thicker skin. So you don't really feel pain like a white person would. So now I'm reading this and I'm going back into the early 90s when my mom broke her ankle. And they refused to give her pain medication until the surgeon got there. And I remember my sisters and I crying because my mother was in so much pain. And they made a good excuse, oh, we can't medicate her because the surgeon's gonna need to speak to her. And she can't be under the influence of narcotics. That actually made sense to us, the way the nurse presented that information to us. That was so wrong. But I'm sure it didn't just happen to my mother. So I ask again, how are we preparing providers to change this narrative when we know in some classrooms we have some colleagues who do not even want to talk about racism? It makes people uncomfortable. But we remember what Baldwin said. Not everything can be changed, but nothing can be changed if we don't face it. So I ask again, is there something that we are failing to face? Isabel Wilkerson, a Pulitzer Prize winner, called out in her book titled Caste, The Origins of Our Discontents. She said that racism goes about its work in silence, the string of a puppet master unseen by those whose subconscious it directs. Its instructions, an intravenous drip to the mind, cast in the guise of normalcy, injustice looking just, atrocities looking unavoidable to keep the machinery humming. Oh, the guise of normalcy, injustice looking just. Do we normalize discrimination in our learning environments? Do we normalize racism? How does that work? Have you ever entertained academic outcomes that are stratified according to race? When we say things like underrepresented minority students are more likely to attrit or fail national exams, and then use the data to affirm false beliefs, like intellectual inferiority, and enact policies that limit racial diversity, that's discriminatory. I can't tell you, I've been a nurse since '86, so many years, and I've been a faculty member for 20. And I can't tell you how many times I've heard from colleagues, look at the data. These students are not passing. We are taking their money. That's an atrocity. And on the surface, it could sound really good, right? Yeah, we don't want to do that. We don't want to take a person's money, knowing that they're not going to be able to graduate. But wait a second, what are our assumptions when we make these statements? Because on the surface, we play around with the numbers and it looks like we're making a case for why we should change admission standards. But the Future of Nursing report and the IOM unequal treatment and all the reports before that speak to the fact that we have to stop looking at the patient, stop looking at the individual for 1 second. I know in the 80s it was all about, it's the patient, it's the patient. They're not a goal, it's the what is the patient not doing? I remember, because I was conditioned to believe the very same thing. But then in the 90s, we said we have to stop blaming the patient. In the 90s, the documents came out to err is human. We have to start looking at the system and how the system is set up. But then at the turn of the century, when the IOM came out with unequal treatment, they said, you've got to start looking in the mirror. Let me tell you, that was a hard pill to swallow, even for myself, an advocate for social justice. And I'm thinking, wait a second, look in the mirror? Are you kidding me? Do you understand how hard we work as providers, as educators? You want to tell us that we could be part of the problem? Yeah, that's hard. It's always easy or easier to blame the patient or the system. But it takes a certain degree of humility to be able to say, I too am part of the problem. Because I too have looked at outcomes and made those assumptions. But when you know better, you do better. And what does that better look like? Well, just imagine if we stratified data based on hair color or height. And we started telling our colleagues, did you notice all of the students with blonde hair weren't able to pass the exam? We'd be in an outroar. What? You can't say that. And I know that because I did one day. Just for effect. And people were outraged. How could you say that? The same way you can say black people failed the boards or failed this. Same way. Because correlation is not causation, and we should know better. But we've inherited practices and policies that we have become immune to. And sometimes we just can't see it until someone calls it out. So in nursing, it took us a while, but last year, we've begun to indict structural racism as not only a driver of health inequities, but academic inequities as well. And last year, the American Nurses Association convened a national commission to address racism in nursing. I was conditioned up until last year not to ever have a conversation about racism. It would never end well. So the report calls out the ways in which the mutagenic qualities of racism have caged us as a profession and stalled efforts to truly graduate providers prepared to eliminate disparities. So as one of the commissioners, I find myself still asking, is there something we have failed to face? In the Future of Nursing report, we emphasize that we will need the courage to engage in difficult conversations about racial inequities. It takes a high level of confidence and courage to have conversations about racism. But besides racism, is there something else in that gap? Is there something else we are failing to face? So I ask, are we rowing this boat called health equity without oars out of the water? We're doing a lot of work, but are we moving? What can we do to move social mission forward? So we know social mission is a concept that Dr. Fitzhugh-Mullen helped operationalize during his pursuit to ensure that health professions education graduated providers who were better prepared to do what our generation and so many before have attempted to do: reduce racial disparities and advance health equity. So as we use the concept of social mission to improve health outcomes for the communities we serve, I want to end with a question. But before that, prior to assuming this role, I probably would have asked you the question that's on the screen. In what ways does structural racism threaten to undermine efforts to advance health equity, and how is your institution addressing it? But because of my role as an associate provost for social mission and academic excellence, I must ask you this. In regard to your research, practices, and policies, is there something you have failed to face? Every generation attempts to build on the work of the preceding generation. Dr. Mullen was only 22 when the CRA of '64 was signed. During his career in medicine, he, like many of us here today, witnessed the ways in which the CRA was neutralized and healthcare disparities continued. I stand here today in part because of Dr. Fitzhugh-Mullen's pursuit of social justice and his determination to bring attention to the ways in which schools could strengthen the ways that future providers are truly prepared to not just address healthcare inequities, but not contribute to them. We are moving the dial to advance social mission, but like the CRA of 1964, we have to recognize our limitations and be humble and consider what, if anything, we have failed to face. Thank you.